بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Today we are going to talk about an important subject in medicine or in surgery or emergency medicine. It is an important topic because of it carries a high mortality and morbidity, and in the United States, for example, 30,000 deaths per year, and small bowel obstruction is more serious than the large bowel. When there is a closed loop, have a high rate of strangulation and a high rate of mortality. Postoperative obstruction, when there is surgery on the abdomen, there is high rate of postoperative obstruction, and this is managed conservatively. Strangulation varies in rate and severity because this serious complication, which is strangulation in intestinal obstruction, is very serious, and the rate and severity varies between several obstructions. Also, intestinal obstruction is 15% of admission from the abdominal pains. All cases of abdominal pain, you will find that 15% which admitted cases is due to intestinal obstruction. As far as surgery is concerned, intestinal obstruction, 20% of the cases needs surgical intervention. If you compare it to other problems, you will find this is a high rate of surgery intervention. For example, if you compare it to other conditions, for example, like trauma abdomen or trauma to the head, brain traumatic injury, you will find that less than 2% needs surgical intervention. The lecture outline, we are going to give the definition of the intestinal obstruction. We are going to give classification of intestinal obstruction, the pathophysiology of intestinal obstruction. We are going to tackle some of the causes of intestinal obstruction, and we are going to talk about the clinical presentation. That means the history, examination, and investigation. That means the diagnosis, and some of the complications of intestinal obstruction and the treatment of intestinal obstruction, both as emergency as a cold operation. If you know the function of the gastrointestinal tract, the gastrointestinal tract is continuous from the mouth to the anal opening, and there are certain functions of this gastrointestinal tract. The functions of the gastrointestinal tract: ingestion, that means deglutition, storage of the food, for example, like the stomach and the colon, they are storage places, and other functions. Deglutition, the digestion of the food, absorption, and at the end, get rid of the waste through defecation. What is the definition of intestinal obstruction? If we said these are the functions, the 4 or 5 things that are the function of the gastrointestinal tract, the definition that function is no longer carried out, it will be jeopardized. But the true definition of intestinal obstruction is It occurs when the passage of intestinal content is interrupted and the distal part is going to become collapsed and the proximal part is dilated. This is the definition of gastrointestinal obstruction. When this obstruction occurs, the functions are disturbed and some of the functions are no longer there. Ingestion will be low because in place of ingestion there is going to be vomiting. For example, storage might be maximized and it will be for a long time if the obstruction is there and the food will not be digested, it will not be propagated by peristaltic movement, and it will not be absorbed. So in place of absorption, a lot of fluid are going to be absorbed to the gastrointestinal tract, and this is against the function of the gastrointestinal tract. The gastrointestinal tract, for example, the small bowel is to absorb the nutrient and chemical like potassium, sodium, and so on. It has to be absorbed inside the body. What is going to happen? The water will be coming to the gastrointestinal tract, and the elements are going to be vomited through the vomiting after the obstruction. What are the classification? Classification of gastrointestinal obstruction is, as we said, there is peristaltic waves which are propelling and expelling the content in the gastrointestinal tract, and this peristaltic wave is two ways. It is forward peristaltic and anti-peristaltic, and this will help in the digestion of the food and will help in the delay of the food and the content, and it will be absorbed. So it is divided into two. Either there is dynamic, which is the force of the peristalsis is there, or it is atonic or adynamic. That means the propulsive forces which are forwarding the content of the gastrointestinal tract are not there. So number one is divided into two, dynamic and adynamic. The second classification is small bowel obstruction, as that means upper, or large bowel obstruction, and that means is lower. In the small bowel itself or in the upper also is divided into two. If it is in the duodenum or jejunum is called high small bowel obstruction, or if it is in the jejunum it is called low small bowel obstruction. The large bowel is in the large colon, and sometimes it have a closed loop obstruction because of the ileocecal valve, which is tight, and it will transmit the expulsion of fluid and content of the small intestine to the large colon. If there is distal obstruction, for example, in the left colon or in the sigmoid, this part of the colon from the cecum, ascending colon, transverse colon, and descending colon, it will be as a blind loop because the obstruction is distal, and there is another obstruction that protects the small bowel, and it is the ileocecal valve, and this is which is called the closed loop obstruction. So for us time, if it is very rapid, we call this is an acute intestinal obstruction. Or if it is taking long time and it is it's more than 1 week and so on, we call it a chronic intestinal obstruction. Between acute and chronic, there is what we call subacute, and there is one which we call acute on chronic. So as far as time is concerned, there are 4 types of intestinal obstruction: acute, acute on chronic, subacute, and chronic. As far as complication, for example, strangulation, if there is associated strangulation of the bowel, we call it a complicated one and we call it strangulated. Or if there is no strangulation, we call it simple intestinal obstruction. And we talked about a separate entity which is called the closed loop obstruction. And the closed loop obstruction is a serious condition and is known for its complication. And as far as it is concerned, a lot of bacteria is going to generate in the blind loop, and it will be absorbed into the circulation and give septicemia, and perforation also is common in the blind loop because it's a two-end obstruction, and distension of the blind loop will occur due to gases, fluids, and other contents, and it might rupture at any time. Dynamic obstruction, what we said, is mechanical. Either the bowel is capable of contracting normally or excessively proximal to the local site of obstruction. This is what we call mechanical or dynamic. That means there is an obstruction distally, the peristalsis will be present because the content is there, and it wants to overcome the obstruction, so the peristalsis might be even stronger, and at the end it will fail. Distal to the obstruction, the bowel will be collapsed because most of the content will go forward, and patient might pass some stool after the obstruction, but later on it will be absolute constipation. The non-mechanical or dynamic one, where peristalsis may be absent completely, and this is what we call alias, or present in a non-propulsive and non-functional form, like the mesenteric vascular occlusion or pseudo-obstruction, which is present sometimes and the peristalsis is dying away. Dynamic causes of dynamic obstruction. In this slide, as I have said, peristalsis is working against a mechanical obstruction, and the adynamic one results from atony of the intestinal wall with loss of normal peristalsis in the absence of a mechanical cause. The lumen is opened. There is no mechanical cause, but the autonomic nervous system, which is making the peristalsis, is no longer working, and the peristalsis either is completely not there, what we call atonia, or the peristalsis is there, but it is in a non-functional way. What are the causes of dynamic obstruction? Dynamic obstruction can be due to 3 causes, either cause in the wall itself of the intestine, like tumors, for example. What we call intramural, that means between the muscles or in the muscles of the wall of the intestine itself, or a stricture, for example, if it is within the wall of the intestine. Or the obstruction is intraluminal, within the lumen of the intestine itself. For example, either impaction of a foreign body like gallstones, or those people who are eating the hair, what we call beeswax, a big collection of hair can pass through the duodenum, and it can obstruct the gastrointestinal tract. Or something from outside the what we call it extramural, outside the tract. It is not from the wall, it is not from the lumen, it is from outside, pressing on the wall of the intestine, like bands after adhesions, or, for example, a part of the intestinal tract which is trapped into a hernial orifice, or even a volvulus, for example. It will rotate and it will obstruct the lumen. Or something, for example, part of the bowel is passing into the other bowel, what we call in children interception. These are the main causes of the dynamic obstruction, either intramural or extramural or intraluminal. The adynamic one or atonic one, or the paralytic one, which is called paralytic alias, is caused by either mesenteric vascular occlusion, which will affect the function of the gastrointestinal tract, the peristaltic function, and this will give you a type of obstruction which is functional, and what we call pseudo obstruction. Usually there are some questions about the causes of intestinal obstruction, but I think each one, for example, a hernia or a volvulus or adhesion or whatever it is, it needs a full lecture discussion. For example, malignancies will be tackled alone. Inflammatory bowel disease will be tackled in another lecture. For example, hernia will be tackled in a separate lecture itself, like we mention it here as a cause of intestinal obstruction. The other causes in pediatrics and children and neonates, for example, it will be taught in pediatric surgery. Usually, if you want to understand the causes of intestinal obstruction, the dynamic one, you have to divide it into intraluminal, what we call intramural, and extramural. And we have mentioned some of the causes. There are some other causes of intestinal obstruction for the adynamic one. For example, metabolic problems like hyponatremia, hypokalemia, which is generated after vomiting and after renal passage of high amount of potassium and hydrogen ion, which is giving also some sort of metabolic alkalosis. Okay. Drugs also might cause intestinal obstruction. Drugs and intestinal obstruction is an important topic. Some of the drugs like opioid might cause a dynamic obstruction and atonia of the gastrointestinal tract. Some of the drugs, like for example, talc powder, people who are wearing the gloves and they are painted with talc powder. This is when they are operating, it might act as a foreign body and cause some adhesions and cause mechanical intestinal obstruction. So drugs and intestinal obstruction is an important topic. Sepsis, for example, gram-negative bacteria, which is causing peritonitis, it can cause early dynamic obstruction. Trauma or surgery, as we said, they can cause atonia of the gastrointestinal tract and peritonitis, which is mentioned also. Head injury and neurosurgery, surgery on the back, also can cause atonia of the gastrointestinal tract and also head injury, and these are some of the important causes of a dynamic obstruction. The pathophysiology is important because the normal physiology of the gastrointestinal tract is to make balance in the fluid and electrolyte and the acid-base balance. But it will be disturbed if there is intestinal obstruction. But the proximal bowel will be dilated and will develop altered motility. It will dilate, the motility will be altered, either it is reduced or increased. In the mechanical intestinal obstruction, in the first place it will be increased because it is working against an obstruction, and it will reach a time and it will fail and stop completely. As we said, the distal part of the obstruction will be dilated and the passage of food will be reduced. Peristaltic strength will be reduced also, and it might reach flaccidity and paralysis. And this will cause perivascular damage due to intraluminal high pressure or increased intraluminal high pressure. For example, if the lumen is dilated and the pressure inside is high, it will press on the blood vessels and it will obstruct the blood vessels and the blood supply of the wall itself, and the nerves which are supplying the wall, it will be affected and atonia will occur. Distal to the obstruction, bowel exhibit normal peristalsis and absorption in the early stages, and then it become empty and collapse because it contracts and become immobile at the end, and absorption completely will be stopped, and even secretion and will be also decreased. Why the distal part of the bowel is distended? Distended because of the obstruction and because of a lot of gases and fluids. The gas is coming from ingested one. Aerobic and anaerobic growth of bacteria will give a lot of gases also. Fluid is collected from digestive juices which are secreted within the gastrointestinal tract, and because of the retarded absorption, because there is high pressure on the wall. The blood vessels are compressed. The absorptive surface is reduced, and the absorptive capacity is also reduced. Dehydration because of the vomiting, because of less absorption, and there is what we call the third space where the fluid is going to, and the patient will lose a lot of fluids. It might reach up to 6 liters. Electrolyte loss also through vomiting and reduced oral intake. If the patient started vomiting, the oral intake will be reduced because he will be afraid of vomiting. And defective intestinal absorption and losses from vomiting will make a lot of disturbances in the electrolyte and acid balance. A lot of fluid is sequestrated in the bowel and lumen, and this is what we call the third spacing. We are going to tackle 3 important things which compromise the major part of the intestinal obstruction and the major causes, and is very common. For example, adhesions and hernias and malignancies. These are the main 3 causes of intestinal obstruction in adult: adhesions, hernias, and malignancy. These are the 3 main causes of intestinal obstruction in adult. For example, adhesion is caused by ischemia to the area. If there is any ischemia to the area, for example, a site of anastomosis after surgery, or a trauma, or a vascular occlusion, the area will be ischemic, and some fibrinous excretion will be there, and then adhesions will occur, and later on it will change. The fibrinous part will change into fibrous part, and it can cause bands, and it can cause complete obstruction. Foreign material, as we said, the talc powder or starch or a gauze, which is forgotten there, or silk, whatever it is, any foreign body which is used in the surgery, it will cause some sort of adhesions. Infection, which is causing peritonitis, also it will cause fibrinous adhesions, and later on fibrous adhesion, like tuberculosis or whatever the bacteria which is there, or like a small perforation in the gastrointestinal tract. Inflammatory bowel disease, which is causing a perforation like Crohn's disease, it will cause also obstruction by adhesions. Other things like radiation, people who are having a lot of radiation like CT scan, and they might have radiation, what we call radiation enteritis, inflammation of the small intestine or large bowel, what we call radiation enteritis. This is also will be prone to adhesion. Anything that will irritate the peritoneum will cause local fibrin production, produces fibrous adhesions between opposed surfaces of the gastrointestinal tract, and it will lead to intestinal obstruction. As early as 4-week post-laparotomy, the majority of patients present between 1 and 5 years. Because in the early stages, if there is an intestinal obstruction in the early stages post-operatively, it will be an adynamic one because of the atonia of the gastrointestinal tract, and this is what we call alias, which is treated conservatively, and later on fibrinous adhesions can occur and it will be treated conservatively, but from 1 to 5 years fibrous adhesions can occur, and this is also a difficult one to treat. It will be treated conservatively in the first place, and then what are the surgeries that will cause adhesions? Colorectal surgery, 25% of the adhesions is caused by colorectal surgery. 20% by gynecological, like cesarean sections, because it's a bloody operation. It is causing a lot of bowel, dealing with bowel and so on, and it will cause a lot of adhesions. And appendectomy, 14% of the adhesion is caused by appendectomies. How to prevent the I hope this one is clear, that adhesion is caused mainly by colorectal surgery, 25%. That means quarter of the adhesions are due to colorectal surgery. 1/5, that means 20%, is due to gynecological surgery, and 15% or 14% is due to removal of the appendix, appendectomy. How to prevent the adhesions, post-operative adhesions? You have to do good surgical technique, number one. Number two, washing of the peritoneal cavity with saline after you finish the operation, to remove the clots which are there. Minimizing the contact to minimize the contact of the gastrointestinal tract with foreign bodies like gauze, like silk, or with touching with the gloves, which is painted by talc powder. Covering anastomosis and raw peritoneal surfaces with gauze and saline. These protective measures can lessen the adhesions which is occurring, but adhesions, some people are prone to develop adhesions. And if obstruction occurred due to adhesion, it has to be treated conservatively, because whenever you open the intestinal obstruction, even if it is subacute, you open it and you do the surgery, you relieve it surgically, it will be formed again and it will be even more intense. As we have said, treatment of adhesion is treated conservatively. At operation, you have to divide the causative band only. Minimal surgery that you can do. Limit the dissection as far as you can to the area of the adhesions only. Don't fiddle with the bowel. Laparoscopic adhenolysis in case of chronic problems. You can use the laparoscope so that you minimize the dissection of the. Important cause of intestinal obstruction is volvulus. That means twisting or rotation of a segment of bowel about its mesentery and forms a closed loop when it is complete. The volvulus is a major cause of intestinal obstruction in elder patients, and it can be primary or secondary. And the sigmoid colon is the commonest place of obstruction, and it can occur in other areas like the cecum, small intestines, stomach, and in neonatal life it can occur as malrotation of the small bowel. Sigmoid volvulus is worldwide. 50% of bowel obstruction is due to sigmoid volvulus, and it is seen in old patients. Risk factors, for example, patient is having a chronic constipation, or he's using a lot of laxative, or it is present in areas where high fiber diet is used. And if the sigmoid colon is having a long mesocolon, a differential diagnosis of sigmoid volvulus pseudo-obstruction can mimic sigmoid volvulus intestinal motility disorders, for example, in old patients who are bedridden and they are there staying in bed or bedbound, and this will lead to autonia of the large bowel and will lead to collection a lot of stool there, and the large bowel will lose its motility, and what this is what we call Ogilvie syndrome. Investigation of sigmoid colon, you have to do plain X-ray, and the plain X-ray will show certain characteristics like the coffee tablet sign, and it will show other signs, the distended loop of sigmoid colon, and it will be like an inverted U. CT scan also can be done, and contrast enema could be done. This is showing how the volvulus will occur. It will occur anti-clockwise. How to treat the sigmoid volvulus intestinal obstruction? Usually the twist will occur anti-clockwise, and when you want to reverse it, you have to reverse it clockwise. In the early stages, it is treated conservatively as far as there is no complication or there is no strangulation, and it could be treated through the sigmoidoscope and try to reverse the twist through a tube or through a sigmoidoscope. Surgically, it can be resected immediately. You can resect the sigmoid and do a Hartmann procedure. That means close the distal part and leave it in the pelvis and get the proximal part as a colostomy. Elective resection of the colon after conservation can be done later on. And in emergency situation where the obstruction is there and the patient is unstable, you can do a colostomy, percutaneous colostomy, and later on do the definitive procedures. Clinical presentation of intestinal obstruction. This is the most important part of this lecture. The four cardinal symptoms of intestinal obstruction is pain, distension, vomiting, and constipation. These are the four cardinal signs. Pain is an abdominal pain. It will be colicky in the first place, and then it will go on when distension is there. For example, in the small bowel obstruction, the distension is upper. In the large bowel obstruction, the distension will be generalized. Vomiting is early with the upper intestinal obstruction. Constipation is late. In the large bowel obstruction, constipation is early, vomiting is late. The history is important in the intestinal obstruction, and you have to be careful of taking the history in the old age or in adult or physical examination entails you have to do a thorough physical examination. That means you have to take the vital signs, pulse, blood pressure, temperature, and you have to examine the skin and see the degree of dehydration and loss of skin turgor. The patient will be tachycardic, tachypneic, with low blood pressure and hypotension. Bowel sounds, either it's absent or increased in the first place. Tender abdomen, you might find localized tenderness in the place of the obstruction, or you might find generalized tenderness and guarding, and you might find a rebound, positive rebound tenderness. Your examination is not complete unless until you do rectal examination and you will find an empty rectum. Investigation, as we said, you have to do a blood so that and see complete blood count, CBC, and urea and electrolyte to see the degree of dehydration, the degree of potassium loss, the degree of sodium loss, and electrolyte. And in any intestinal obstruction, X-ray, plain X-ray might help, because the rule of 369, that means the small bowel is 3 centimeters in diameter, and the large bowel is 6 centimeters in diameter, and the cecum is 9 centimeters in diameter. And you will, in intestinal obstruction, you will find this rule is, you will find the small bowel is dilated beyond 3 centimeters, and the large bowel is above 6 centimeters, and the cecum is above 9 centimeters. And how to differentiate on the X-ray between the two, how to differentiate between the small bowel and the large bowel obstruction, or how to differentiate between the loops of small bowel and large bowel dilatation. Large bowel, anatomically, it is on the periphery. Small bowel in the center. Small bowel is having what we call valvular conventis, which are continuous, are all around the wall, while the large bowel is having what we call the haustration. The haustra is not the segment is not complete. You will find it on one side of the large bowel. In intestinal obstruction, you can do ultrasound to see some of the organs and to see if there is a tumor or no tumor. Barium studies is helpful. Endoscopy, and we are going to concentrate on this for investigation later.